Rehabilitation and risk, childhood norms, antisocial pathways, and what we can realistically change. Introduction. While studying abnormal psychology and serial offenders, I encountered a broader and more troubling pattern. Many people carry sociopathic or psychopathic tendencies without ever committing violent crimes. These tendencies arise from interacting biological risks and developmental environments that normalize antisocial strategies early in life. The central question is not whether such people are irredeemable monsters, but whether rehabilitation, psychotherapy, and social interventions can reduce harm and alter life trajectories. This essay integrates what we know about definitions, developmental origins, which targets professionals can realistically change, effective treatment approaches, prognosis, and the ethical and policy implications for extreme cases. Definitions and the trait versus behavior distinction. Antisocial personality disorder (ASPD), defined by persistent rule-breaking, criminality in some cases, and impaired social functioning. Psychopathy is a research construct emphasizing callous affect, shallow emotions, grandiosity, manipulativeness, and often instrumental antisocial behavior. Sociopathy is a looser term used for presentations more strongly shaped by environmental adversity and impulsivity. Trait versus behavior distinction matters because behaviors, violence, deception, substance misuse, are generally more amenable to change than deep affective traits, callousness, lack of remorse. Realistic treatment goals depend on whether clinicians target observable behaviors, learned social heuristics, or core affective architecture. Origins and contributing factors. Biological foundations. Genetic predispositions, temperament, e.g., low fear or high reward sensitivity, and atypical neurocircuitry for emotional processing, reward learning, and impulse control increase risk. Biological factors set a range of probable responses to environmental inputs, rather than determining a single immutable outcome. Developmental environment. Early caregiver patterns are foundational. Consistent, attuned caregiving scaffolds moral learning, empathy, reciprocity, and trust that others will respond predictably. Neglect, emotional unavailability, harsh or inconsistent discipline, and exposure to domestic violence interrupt that learning. Children in those contexts learn different social rules, self-reliance, emotional suppression, instrumental use of others that can crystallize into antisocial strategies. Reward learning and reinforcement. Children encode what behaviors produce desired outcomes. Where manipulation, coercion, or aggression reliably yield food, protection, status, or escape, those behaviors become normative heuristics. Short-term reinforcement makes antisocial strategies habit-like and automatic. Emotional socialization and attachment. Repeated invalidation of emotional expression blunts effective learning. Secure attachment creates expectations of reliable caregiving. Insecure or disorganized attachment teaches that others are unpredictable or dangerous, favoring guarded, self-serving social strategies. Peer and community ecology. Schools and neighborhoods that tolerate bullying, exploitation, or violence amplify antisocial norms. Peer groups can teach and reward callous strategies, integrating them into identity and social skill sets. Neurodevelopmental effects of chronic stress. Cumulative adversities, material deprivation, chronic threat, repeated loss, reshape stress response systems and neural circuits for emotion regulation and reward. These alterations increase impulsivity, reward-seeking, and blunted threat sensitivity, making antisocial tactics both more likely and more effective in the short term. Heterogeneity and developmental pathways. Multiple routes to similar outcomes. Not everyone labeled with antisocial traits shares the same etiology. Some profiles spring primarily from temperamental fearlessness, interacting with mildly adverse environments. Others result mainly from severe, early adversity and modeling. Most people reflect a mixture of biological susceptibility and environmental shaping. Timing and sensitive windows. Norms established in early childhood, especially the first 5 years, scaffold later learning. Interventions that arrive earlier have disproportionately larger effects than those that start in adolescence or adulthood. Subtypes shaped by development. Bold, manipulative profiles often linked to low fear temperament, coupled with permissive environments that fail to constrain exploitative strategies. Impulsive, reactive profiles usually reflect chaotic, violent, or neglectful caregiving, that models aggression as survival. Many cases fall between these poles and respond differently to interventions. What rehabilitation realistically means: primary aims and realistic endpoints. Rehabilitation is best framed as measurable harm reduction and functional improvement, rather than wholesale personality replacement. Realistic goals include reduced violence and criminal offending, improved impulse control, sustained substance abstinence, better problem solving, and increased prosocial functioning such as stable employment and relationships. Measurable outcomes that clinicians and systems can track include decreased recidivism, fewer violent incidents, improved performance on standardized measures of criminal thinking and problem solving, attainment of vocational goals, and reliable adherence to treatment or supervision requirements. When change is most likely, change is more likely with early intervention, long duration and structured programs, strong contingency management that consistently rewards prosocial choices, and post-treatment environments that reinforce new behaviors, stable housing, employment, social supports. What professionals can reduce or fix: antisocial behavior patterns through skills training and contingency systems, criminal thinking and cognitive distortions via adapted CBT, substance misuse and mood instability with integrated treatment, poor decision-making through rehearsal of alternative heuristics. These changes often translate into meaningful community risk reduction. What is resistant to change? Core affective traits: enduring callousness, shallow affect, lack of authentic remorse, and a fundamentally fearless temperament tend to be resistant to full transformation. Such traits frequently require management strategies rather than cure. Effective methods and their limits: cognitive behavioral interventions, adapted CBT that addresses criminal thinking, replaces short-term reward logic with long-term planning, and rehearses prosocial norms, reduces antisocial behaviors when delivered intensively and with fidelity. Skill building and behavioral management, emotion regulation training, social cognitive skills, behavioral empathy rehearsal, and contingency-based reinforcement lower risk by changing what a person does in high-risk moments, even if underlying affective dispositions remain limited. Integrated, long-duration programs, combinations of CBT, relapse prevention, vocational training, and substance use treatment show the best outcomes in forensic and community settings because they shift both internal capacities and external contingencies. Effective traits and empathy training. Empathy can be taught at a behavioral level, recognizing cues, acting with simulated concern, following social scripts, but changing core callousness and shallow emotional experience is markedly difficult and often incomplete. Medication and neurobiological approaches. Medications can treat comorbid conditions such as impulsivity, ADHD, irritability, and mood disorders, and thus indirectly reduce risk. There is no pharmacological cure for psychopathy. Prognosis factors. Professionals can influence improved prognosis when treatment begins early, is consistent and tailored, addresses comorbidities, uses contingency-based learning, and is followed by a supportive environment. Clinicians can substantially reduce harmful behaviors and improve functioning, but must often plan for long-term management of affective traits. Extreme cases, public safety, and ethics, risk management, and multi-agency responses. Individuals who repeatedly cause serious harm may require secure settings and coordinated multi-agency management focused on public safety, while offering evidence-based rehabilitation to the extent possible. Moral framing and the danger of dehumanization. Labeling people as monsters is counterproductive. It alienates potential treatment windows, degrades ethical policy, and reduces the chance of preventing further victims. A humane but pragmatic language focused on risk, harm reduction, and accountability preserves moral clarity without foreclosing intervention. Balancing rights and protection. Forensic systems must balance rehabilitation opportunities with robust risk assessment and victim-centered safeguards. Ethical policy requires transparent criteria for containment, clear pathways for treatment access, and periodic reassessment tied to measurable behaviors. Research limitations and priorities. Many neurological and clinical studies rely on post-conviction samples, creating selection biases and limiting causal claims. Longitudinal, pre-conviction, and ethically designed developmental research is needed to identify early protective mechanisms and refine interventions. Practical recommendations for clinicians, researchers, and policymakers. Clinicians prioritize measurable harm reduction goals, treat comorbid conditions aggressively, adapt CBT to target criminal thinking, use contingency management, and plan for long-duration engagement and environmental supports. Researchers invest in ethical longitudinal and pre-conviction studies, study mechanisms of resilience, and test early prevention models that alter caregiving and school-based socialization. Policy and public fund early family and school-based interventions, support community reintegration services, housing, employment, mentoring, and adopt language that emphasizes risk management and rehabilitation rather than dehumanizing labels. Extreme cases, public safety and ethics. Risk management and multi-agency responses. Individuals who repeatedly cause serious harm may require secure settings and coordinated management, emphasizing public safety, while offering evidence-based rehabilitation when feasible. Moral framing and the danger of dehumanization, calling people monsters, undermines treatment windows and ethical policy. Pragmatic, humane language focused on risk, accountability, and rehabilitation preserves moral clarity without foreclosing intervention. Balancing rights and protection. Forensic systems must balance rehabilitation access with robust risk assessment, victim-centered safeguards, transparent containment criteria, and periodic reassessment tied to measurable behavior. Research limitations and priority selection biases in post-conviction samples limit causal claims. Ethical longitudinal, pre-conviction, and prevention research is needed to identify protective mechanisms and refine interventions. Possible outcomes if these issues are not addressed during childhood or adolescence. Entrenchment of antisocial heuristics. Short-term reinforced strategies, manipulation, coercion, deceit become automatic social rules, reducing the probability that later interventions will outcompete those heuristics. Escalation of risk behaviors. Untreated trajectories often show increasing severity. Earlier conduct problems can progress to more serious offending, substance dependence, and violent acts as opportunities and skills to exploit others grow. Compounded comorbidity and functional decline. Untreated ADHD, trauma, learning problems, and mood disorders accumulate, producing academic failure, job instability, homelessness, and worsening mental health that reinforce antisocial choices. Social isolation and identity consolidation. Peer groups or subcultures that reward antisocial strategies can harden identity around those behaviors, making prosocial alternatives less salient and less rewarding. Neurodevelopmental reinforcement of maladaptive patterns. Prolonged stress and adversity further dysregulate stress response and reward systems, increasing impulsivity, blunted threat sensitivity, and anhedonia, which reduce responsiveness to standard therapeutic incentives. Increased victimization and community harm. Higher rates of criminal activity, exploitation, and interpersonal violence produce more victims and amplified social costs, public safety burdens, healthcare utilization, and collateral trauma across families and communities. Cycle of intergenerational transmission. Children raised by adults who model antisocial heuristics are at greater risk of inheriting similar norms and environmental exposures, perpetuating cycles of adversity and antisocial strategies. Greater demands on forensic systems and reduced rehabilitation yield. As behaviors escalate and traits consolidate, forensic systems face higher containment costs, longer secure placements, and lower probabilities of successful community reintegration. Diminished social capital and civic functioning. Communities with concentrated, unaddressed antisocial trajectories suffer from weakened institutions, reduced economic opportunity, and fraying trust, conditions that further entrench antisocial norms. Net effect: failure to intervene early increases individual suffering and public harm, while making later rehabilitation more difficult, more expensive, and less likely to restore adaptive functioning. Sociopathy and psychopathy are heterogeneous, developmentally grounded phenomena emerging from interacting biological susceptibilities and social environments. Childhood and adolescent environments create social and emotional norms that can normalize antisocial strategies. Those norms, once consolidated, shape trajectories toward harm for individuals and communities. Meaningful rehabilitation is possible in many domains. Professionals can reduce antisocial behaviors, treat comorbidities, teach compensatory skills, and support reintegration. but deep affective traits often resist full transformation and require long-term management. The highest returns come from early prevention, long duration, integrated interventions, and social policies that repair environmental contingencies. Ignoring these developmental windows increases individual and social costs and narrows the realistic options for reducing harm over the long term.